Sir, some papers suggest that the intracapsular fracture neck of femur should be fixed within 12 hours after surgery.
Yeah, so that paper is from Swinkowski. It's an American, North American surgeon, and he suggests that all neck of femur fractures should be done in the next available list, which has got senior cover and experienced staff in theatre. You can't just take the patient in the middle of the night when nobody knows what's happening and you're trying to pull it and fix it and open it and it won't work. So you need to say that this is a young adult, 40-year-old. He has an intracapsular neck of femur fracture. This is displaced. I would inform my seniors and I would inform the anesthetist. I would actually do the ATLS protocol and make sure that this is an isolated injury after confirming medication, and there is no contraindication. I will plan for this patient to have surgery on the next available fully staffed list. Okay?
Okay, sir. Okay.
So what did Swinkowski say very specifically about intracapsular fractures in necks?
Sorry, sir, I did not get you.
So what was the paper, what was the most important bit of that paper that said that when you have intracapsular fracture, that hematoma inside the capsule will cause problems with the vascular supply of the head, and therefore it is not displaced. You need to make sure that that hematoma is respirated or open at the time of surgery.
Other participants, please mute your phones. Other participants, please mute your phones.
So this is not respecting education by talking to other people while being in a meeting. You know, this is one of the reasons I gave it up, because nobody was wanting to learn. They just want to come in and then anyway. So what type of fracture is this?
Sir, fracture neck of femur, basi cervical.
So it is an so don't make fancy statements, you know, make it as simple as you can. It's an intracapsular displaced fracture. That's what you have to say.
Sorry, sir. My internet was disrupted. Okay. It looks like fracture subcapital neck of femur.
Okay, well, see, you guys, you know, get questions to you yourself by making statements. You know, why do you want to call it a subcapital fracture? Why can't you keep it simple and say it's an intracapsular displaced fracture? Okay, so subcapital can be intracapsular, can be extracapsular. Do you agree?
Okay. Okay, sir.
So don't make statements that will ask another question instead of getting you moving on to the next thing. Yeah. So this is an intracapsular displaced neck of femur fracture. Okay. So what are your options in a 40-year-old?
Sir, cannulated hip subcluse.
Okay. So again, we don't operate on people unless we know what kind of person it is. He may be a 40-year-old, but his physiology may be 90-year-olds. Okay. So the answer to this is very standard, assuming that there is no contraindication to surgery, patient is fine, and their HLS protocol is stable. My plan of procedure would for this patient be, and then when you give a plan, you have to justify why you do want to do it. So you should not say 5 options. You should say my plan is I would do intracapsular neck of femur fracture like this in a young adult by reducing it, and I would put screws to hold it together. Okay.
Okay, sir. Okay.
That is one method. Okay. So when you do this, do you know of any maneuvers that you need to know for reducing the neck of femur? Because we don't normally reduce neck of femur fractures.
Sir, by putting the patient on the
I asked for a maneuver.
Traction table.
Ledbetter's maneuver. Yeah. Do you know that Ledbetter's maneuver?
Sir, flexion and abduction.
Yeah.
And external rotation.
Traction. First traction, then flexion, abduction, and then extension again to reduce it. Okay, the image will help you. Now, once you reduce it, you hold it with one wire and then put 3 screws, minimum 3 screws. Okay, why do we use 3 screws?
Sir, we use 3 screws so that the fragment don't get rotated. We actually put 3 screws in the inverted triangle shape,
So
And
don't give information that's not been asked. If somebody asks you, why do you put 3 screws? Then you say evidence supports that 3 screws are better than 2. And with 2, there is no rotational instability. With 3, there is rotational stability. Yeah?
okay, right, sir.
Simple.
Right.
So that they can move on to another. So do you want to start again and refine your statements? So this is the exercise that's been shown to the exam. You will very correctly say, I cannot comment on this X-ray unless I see the lateral view. The examiner will say, this is the only view, there are no lateral views. Can you now comment on it? And then you start commenting on it. So can you tell me what this is?
So this is a P radiograph of the skeletally mature patient, focus over the hip joint, undocumented site, and
So which side do
the
you
most
think?
obvious finding.
Which side do you think it is?
No,
It's the right side, isn't it? Yeah.
it's right side. The most obvious finding I can appreciate there is the intracapsular fracture, which is displaced and rotated, and angulation is increased. Sorry, it's and there is
So why are
no
you giving me all this information? Again, we said it in the last talk too. You just give enough information so that the examiner can move on. If you keep saying things, most examiners are of 2 types. One would listen to whatever you want to say and not stop you and let you go until your time's up. And the second examiner will try to stop you so that you can move on to the next stage. So you should preempt that, and you tell the examiner that this is a X-ray showing a right hip of a skeletally mature person who has an intracapsular displaced fracture of the right side. And once you say that, give a second pause, not more, just a second pause, and see what the examiner is doing. Is he wanting you to continue, or is he going to ask you a question? Most examiners will ask you a question, okay? And the next question would be that what is your plan of management, okay? And plan of management does not mean classifying types of procedure. Plan of management is I'll stabilize the patient, assuming HLS protocol is dealt with, isolated injury, no contraindication of surgery. I would look for the next available fully staffed list to try to do an internal fixation and reduction of this fracture, which would be screws in your hand. Okay? Make sure that you do simple examination, simple answers, and not do too much information, because some examiners will let you do that and your time will be up and you will only answer one question the whole time.
Right, sir. Right.
Do we get that?
Yes, sir. Yes, sir. Thank you. Thank you, sir.
When will you do a hip replacement here?
Sir, if the age of the patient is around, patient, we'll take complete history of the patient and bone quality. We'll check on the X-rays the bone quality of the patient, and if there is avian avascular necrosis of the head, time is already that's the injury is old, and so we
for doing a hip replacement fully fit adult is what? Just one indication. So,
sir, avian of the hip.
Sorry?
Avascular necrosis of the hip, sir?
No. Arthritis would be the only indication in a young adult of 40-year-old to put a hip replacement in there, isn't it? If there is no arthritis of the acetabulum and the acetabulum is normal, you can put a monoblock, or you can put a modular hemi in here. And if you put a modular hemi in here, your reason is that you may come back in the future and do a hip replacement or convert it to a hip replacement. Okay, so most young people you have to fix. Okay, the only reason or indication to do a total hip replacement is when there is arthritis on the acetabular side. Now, if you have a young person and the head is dead, or there is avascular necrosis, or you think that's going to die, then you can do a hemi here, right? And a hemi will be okay if it's a modular one, and you can come from a bipolar and replace it. The reason you don't want to do a total hip replacement in a young 40-year-old is that this will fail, okay, in the next 10 years, 15 years. So why do you want to do a hip replacement? To make it into a revision if there is no arthritis on the acetabulum. Okay, so that's the only indication in trauma to do a total hip replacement in a young person. In an older person, if he's fully fit and is mobile and does not need walking sticks, then he can have a total hip replacement. Otherwise, you do a hemi. So there is a paper published that 75 above and 75 below and quality of life. Okay.
Okay, sir. Okay. Okay, sir.
So now tell me, in this particular patient who is a 40-year-old, and you have done a screws, 3 screws, a very good purchase. Now, what is the post-op instruction you will give to the physio and to the patient?
Sir, first of all, I will consult the patient regarding the weight bearing, and we'll start the protocol of the physio and pain management. Non-weight bearing will be around 6 weeks, and it will be with the help of partial weight bearing by using crutches. And second will be uh, for early mobilization, sir. Different hospitals have different protocols regarding range
You
of
don't work in different
physio.
hospitals, you work in one hospital. All you can tell this person is, if it's a young person, I will fix it with screws. I will have a protocol that my department follows. And your department, most of the department will say that I will get pain relief, get the physios involved, and non-weight bearing for the first 6 weeks. Depending on what the x-ray shows and how fit the patient is, I will start partial to full weight bearing. Okay? So you need to be
Okay,
very
sir.
clear with what you say. So what is partial weight bearing?
Sir, partial weight bearing, I mean, the patient will only touch the 4 foot on the ground, and will use crutches on that side
Is
for
there a scientific
what?
definition of partial weight bearing?
Sorry, sir, I could not get you.
Is there a scientific definition of partial weight bearing?
No, sir.
There is. I wouldn't ask you if there wasn't.
Yes, sir, there is.
Go on then.
Sir, we took a weight machine and asked the patient to put a weight by operated leg. Then suppose patient weight is 60 kg and we allow for partial weight bearing. Then we ask him to put like 20 to 30 kg. Like we put the feet and ask him to put weight, increase weight till it get 30 or 25. So
So the
we
answer is
train
very
the patient.
simple. Very good. Yeah. The answer is very simple. First of all, is you will ask you'll find and calculate the total weight of the patient, and then you ask and then you calculate a third of that weight, and then you ask the patient to put the foot that has been operated on the weighing machine until it shows the third body weight, and that's the amount of weight he's allowed to put on when he's doing partial weight bearing. Agreed?
Okay, sir.
So we all tell everybody to go partial weight bearing, but we never tell the patient what to do. Okay, so the next question is, if this was a 85-year-old, would your plan of management be different?
Yes, sir.
Go on then.
In that 85-year-old, I will check the mobility status of the patient, the comorbids, and if there is no contraindication of the surgery, and there is no arthritis on the stapler side, and the patient is not community immobilizer, then I will go for hemiarthroplasty.
Okay, so the quickest answer is, assuming that the patient is fit, he has no contraindication, my choice of procedure, depending on the patient's mobility, would be either a hemi or a total.
Yes, sir.
Okay, that's a lot more clear. You know, today we're not going information, we're trying to get technique right today, okay? So,
Okay, sir.
right, so if this person is a mobilizer and is community mobilizer, then you can do a hip replacement. If the patient is not a community mobilizer, then you do a hemiarthroplasty. Okay.
Right, sir. Agreed. Agreed.
Okay. It's easy. I mean, exam is not difficult. We make it difficult ourselves.
Right, sir.
Okay. Can we do one more and then we'll call it a day? And the next time when we come in, we'll talk hip, but we need to know, you know, what is the mortality? What is the morbidity of it? How long do these last? What is the chance of having a second fracture? You know, all these things, the Nottingham hip score and all that kind of stuff we need to put into knowledge. But today is technique only. Okay. Shall we go somewhere else? this one. This is a 65-year-old who had an open fracture about a year ago. He was manipulated, and it was decided that he needed to have a plaster management. He is now 1 year down the line. There is no infection, the skin's all closed, and he has pain walking. What is your view on this X-ray? Who wants to go? Does anybody else wants to go?
Should I continue?
No, we'll all have to have a chance here. It's not fair. I don't like when nobody wants to
Yes, sir.
participate. It just annoys me all the time. Like, you know, we're here to learn. I mean, I don't get angry. I don't shout. I don't scream. I don't make fun. So if you don't tell me what you want to tell me, participate here, then the exam you're definitely not going to do well. So the whole idea of doing this is for other people to get involved so they can have the ability to talk.
Yes, sir.
So, Rizwan, yeah?
Yes, sir.
Okay, come on then.
So this is a plain radiograph, a AP view and lateral view of the undocumented patient showing the knee joint and ankle joint not visible. Among the positive finding, there is
What's a positive finding? It's not an electric current, isn't it? Like, you know, this is
positive finding is the non-bridging callus over the proximal 1/3 of the tibia, and there is a gap showing the radiolucent area, and the
so what does that
fibula
actually
looks to be
mean?
united.
There's a gap and radiolucent area and all that kind of stuff. So there is still
There is a
fracture,
gap.
there's still fracture non-union. The fracture line is visible, yeah?
Yes, sir.
Now, if you look at this X-ray, what type of union is going on? And the answer to the question was in the history.
I can't listen the history.
Okay, the history was this person was managing a plaster a year down the line and he's still in pain. It's a closed injury, there is no infection, wounds all healed.
It is atrophic non-union.
Is it?
Atrophic non-union.
Okay, there's some callus going all around. Can you see that? It's not a
Yes,
typical
yes.
hypertrophic union, but in a plaster, you get a hypertrophic non-union, isn't it?
Yes, yes.
What does that mean?
Yes, it is.
What does that mean?
And improper immobilization was given to the patient, so
That
the
means the surgeon
callus could not be
whoever
formed.
was an idiot, like isn't it? You can't say that in an exam, that improper. What you can say is stability was not maintained.
Stability is not maintained.
Yes, if stability is not maintained,
Yes.
the fracture will move. And if the fracture moves, there will be non-union. And if there is non-union, it will not unite. And then there will be callus stopping it from uniting. And the fibula is also, you know, touching each other, so it's not allowing it to collapse into the right place. Okay.
Right, sir.
How does fracture heal?
I have goals that the stabilization should be given proper, and the fracture have the
So do you know the basics of it,
end-to-end.
biologics of it? You know, you're telling me the mechanics of it now. So what's the base? How does a fracture become a callus?
There should be no mobilization. The proper stability should be proper, and the soft tissue coverage and blood supply should be
How does
adequate.
biologically it heals? You have a hematoma, right?
The hematoma organized,
Yes. Then what happens then?
organized and form the callus.
It doesn't directly form the callus. What is the one thing that makes the hematoma into fibrous tissue, into cartilage, into bone?
Yes.
It's called relative strength. The more the movement is, the less the fracture is going to heal. And the stimulus to change from fibrous tissue and cartilage to callus is the relative strain. And if they have less movement, more stability, then pH will change and become a callus. Okay, well, that's for knowledge, we'll talk about it. So this patient had no, stability, and therefore this is now gone into non-union. We think it's a hypertrophic non-union, and therefore it's a good thing, it's not a bad thing. Okay, a hypertrophic non-union is a good thing because
there is attempting to make a
It's trying
bone
to heal.
and
Trying
from
to heal
the
because
callus.
instability is not. So if you give it stability, it will heal. What happens in atrophic non-union then?
The biomechanics are not working and the body is not attempting to heal it
Yeah, but it's in both cases.
naturally.
What is the difference between atrophic and hypertrophic? In atrophic, the process of healing has burnt out. Okay. And so you have to
Yes.
restart the whole process by freshening the edges, put bone graft into it, stabilizing it. In hypertrophic non-union, all you have to do is if you stabilize it, it will start to heal. Okay, so what is your plan of management for this particular case then?
I will do open, considering this is the isolated injury, and I will consult the patient about the operative management of the patient and go for open reduction internal fixation with bone grafting.
Okay, that's one option. What other options can you do?
Other options, give the intramedullary nailing.
Yes, you can. What complication or problems will you face in intramedullary nailing? Yes, it's an option. I'm not disagreeing with it, but what are the problems you will face?
I don't know about the
So the ends of
difficulty level.
ends of the bones will be closed because you have callus growing into it, isn't it? So it would be not easy to put a nail into it, but you can by either putting a sharp instrument through it to open it or open it at the fracture site and refreshing the edges for the nail to pass through. And you may have to do a fibular osteotomy at the same time. Okay.
Yeah.
Now you have a choice of plating
Yes,
it, you have a choice of putting a nail in it. What other options you have?
I will go for a circular frame for compression.
So what is the problem with frames or fixators? It's a recipe for non-union, isn't
These
it?
are the cumbersome to the patient.
Well, not cumbersome. Most fixators are recipes for non-union. If you have to do it, it has to be an allograft frame, which causes compression to the site, and you can change the forces onto it. A straightforward monoplanar fixator will not work in this particular instance.
Yes.
Okay, now if you go back to the very first day, what would your ideal plan of management for this patient be? You know, this was managed in a plaster. What would you do?
I will if to manage it into the plaster.
So this was done in the plaster
Sorry?
and left for a year, and after that it didn't unite. So now we're working. So the first operation is always the best operation, the best time to sort it out. So if this patient came in fresh first time, what would you do?
I will go for intramedullary nailing at the first time because it is early, give early mobilization to the patient and unites well.
Okay, so there is evidence to support it and go against it, but of all the patient issues we have, in a tibia, the intramedullary nail is the best option. Okay, what are
Yes,
issues
sir.
with intramedullary nail in open fractures?
Surgical, it is might be a source of embolism and source of infection and implant impingement and knee pain.
So in an open fracture, the periosteum is stripped, and then you're doing a reaming, which is an endosteal reaming, so that the blood supply to the bone is gone from outside and from inside. That's the only issue with intramedullary nailing, and it does have issues with throwing embolus. And if you have a major road traffic accident, then it can develop complication, and you can have the SIRS and MODS and the respiratory distress and all that kind of stuff. Okay.
Yes, sir.
Okay, so this is the last thing we're going to discuss in sorry, one, isn't it? I want you now to talk about this as you would do in the exam. So polish what you said earlier, because today we are talking about technical knowledge. So this is a skeletally mature one. Repeat what you said earlier, but more refined now.
Yes. Sorry, sir, I can't hear you properly.
Okay, you can't hear me at all?
The voice is so low that I have difficulty in listening.
Okay, so it's a very simple, straightforward question I want you to answer. Whatever you said to me earlier, only say it again, but this time make sure that is more refined and polished and you've learned from the discussion. That's all I want you to do.
Yes. This is a skeletally mature patient showing the AP and lateral view of the tibia, showing non-union of the
Non-union बताया है क्या बताया?
Go on.
There is a little callus attempting to be formed at the lateral radiograph, and I would like to have a full radiograph with the ankle joint and lab investigation to rule out any infection, and then I will.
There is no infection, and your X-rays are okay, but I only have this one. How would you know there's infection?
I will look for this CRP levels and any discharge over the.
So you can look at it
fracture
clinically. You
site.
can look at it through the lab, yeah. So can you
Yes, yes.
appreciate what you can see on the femur here? Do you know what that is?
This is the osteopenia.
Yes, this is from immobilization in the plaster for too long, yeah.
Yes.
Okay, so now listen carefully. This is what we're going to do in the exam. In the exam, you're going to say this is a radiograph of a skeletally mature person showing an AP and lateral of the tibia. It shows a mid-shaft fracture attempting to heal. There is evidence that there may be hypertrophic non-union. So I feel that this fracture was fixed with instability, or there was no stability for the fracture. So if this is still symptomatic, my plan of management would be to revise this fracture. The options I have and the best ones in my hand would be to open it, reduce it, stabilize it with a plate, and possibly put bone graft into it. Okay? So this is the answer
Right,
to
sir.
the exam. Very sophisticated, very clean, and very polished. And this can go for anything.
Right, sir.
You know, tibia, femur, hand fractures, humeruses, heart fracture, whatever. Just you need to have a plan and a method of talking to the examiner.
Right, sir.
The
Right,
most
sir. Right.
important thing is don't give too much information too soon. You need to give enough information and then judge what the examiner wants. Does he want you to keep talking, or does he want you to ask the question? Now, I am not 100% sure what the examiner in Pakistan, but everybody has 5 to 6 questions. Okay?
Right, sir. Right.
You all understand? We'll do this again on Sundays. I have time on Sundays at this particular time for an hour because I have made myself too busy with my family and various other things. It's not work related, it's just family things. So I will come on Sundays. So do you want to do another talk on technique, or should we go ahead and start talking about knowledge?
So next Monday, we have exams.
Is it?
We have exam on the next Monday.
So do you want to do another one in the middle of the week somewhere?
Yes, sir.
Okay, I will look at my diary and then I'll let you know. But I mean, nobody asked me to start. I would have done it earlier. So should we do that somewhere during the week? Let me know, and then I can come back and we can do whichever you find a difficult topic to talk on.
Right, sir. Right.
Do you have any topics that you wanted to talk on?
We feel difficult the carpal injuries or hand, wrist and hand.
Okay, we can do wrist and hand somewhere during the week then. If you let me know,
Yes.
I have got already some X-rays and slides, and I can put them together, and we can do carpal instability.
Yes.
It is a very simple topic. You know, there are no skeletons or red herrings in it. It's just a very straightforward topic. But yeah, we'll talk about it. Okay, let me know. Okay, should we call it a day?
Okay, sir.